What are some of the most important papers that were published in the past year in hypertension and in the field of public health and epidemiology? My name is Professor Alta Schutte, and herewith I will present to you three of my highest priorities in terms of papers published recently. Of course, there were many that were competing. So first of all, I would like to present the paper by the Global Burden of Disease Risk Factor Collaboration, which was published in the Lancet last year. The GBD collaboration is very well known globally for the work that has been going on for several years now. And in this specific paper, they looked at data since 1990, so a few decades spanning the data, and for 204 different countries. They ranked also 87 different risk factors in terms of their contribution to burden of disease and death. And I think everybody's by now quite aware of their rigorous analysis of levels and trends of exposure to these leading risk factors. So what they found when ranking these risk factors were that in females in 2019, high systolic blood pressure by far was the leading risk factor contributing to deaths. And that was followed by dietary risks, high plasma glucose, etc. When we look at males for 2019, the leading risk factor was tobacco, whereas high systolic blood pressure was second. And this just gives us a broader picture in terms of where are these priorities and how important raised blood pressure actually is. We need awareness, we need much more interventions to really improve blood pressure control globally, to reduce blood pressure low and reduce risk. The authors of the paper also indicated there that when taken together for males and females, the leading risk factor globally for attributable deaths was high systolic blood pressure, accounting for 10.8 million deaths in that 1 year, of which almost 20% of all deaths was due to raised blood pressure. And that is a tremendous amount of risk with elevated blood pressure. And therefore, I think this is really an important paper to take note of. Although during the past years, it's always been high blood pressure that ranked the highest. And I really hope that will change soon. The second paper I would like to highlight is that from the COBRA-BPS study group. And that is because we shouldn't forget about the fact that about 75% of raised blood pressure burden is carried by low and middle income countries. And therefore, we need to also think about interventions that would be applicable globally, also in high-income countries, but particularly in low and middle income countries where we know the health systems are typically overburdened. And what is great about this study is it was an intervention in 3 different countries, a cluster, a randomized controlled trial, in rural areas in Bangladesh, Pakistan and Sri Lanka, where communities were randomized to receive usual care when patients had high blood pressure, or to receive a multi-component intervention. So this intervention group, this was really led by community health workers that were trained. So they were already employed by government community health workers. So they were trained to do blood pressure monitoring, counseling, training of physicians and care coordination in the public sector. So they did a lot of the connections with patients to ensure that care is improved, understanding is improved, awareness and monitoring is improved. And the primary outcome was systolic blood pressure after 24 months. And the study was actually quite successful, with more than 90% of participants completing the trial. And the authors found a significant reduction in systolic blood pressure after 24 months in the intervention group, about 9 millimeters of mercury compared to 3.8 with usual care. It was a major intervention, and it really aligns also well with the World Health Organization HEARTS packages, which really emphasize the importance of team-based care, that everything shouldn't be only done by physicians or medical doctors, because of the really physician-to-patient ratio that's really under pressure in these low and middle income country settings. And therefore, this sort of intervention where community health workers and nurses could play an important role should really be highlighted and expanded on. I think further interventions that could be also linked to community healthcare worker could be, for example, the use of polypills or single pill combination therapy that's linked to this intervention, but it would interesting area where things are developing now. So I think this is a great paper that was published recently. The last paper I would like to highlight is this one from the blood pressure lowering treatment Triallists, which is really a very impactful paper where they looked at pharmacological blood pressure lowering for both primary and secondary prevention of cardiovascular disease. And what they really focused on was different levels of blood pressure. We know after the SPRINT trial, also there were lots of discussion on the benefit of reducing blood pressure much lower than the traditional targets of 130, for example, for systolic blood pressure, 140, 130, 120. And therefore, what the Triallists collaboration done was they analyzed individual patient data, IPD, from randomized trials to investigate the effects of blood pressure lowering treatment on the risk of major cardiovascular events. And this was done by baseline levels of systolic blood pressure. This actually demonstrates the main findings of the trial very well. Patients with cardiovascular disease, those without cardiovascular disease. And it really demonstrates here, when you look at major cardiovascular events, the rates of major cardiovascular events per 5 millimeters of mercury reduction in systolic blood pressure. And here you can see in both those with or without disease, there's a major benefit in terms of the hazard ratio for improvement in terms of risk over 5 years, and it's expanding even as time goes on. So the authors interpreted this, namely that this large-scale analysis, that a 5 millimeters mercury reduction of systolic blood pressure reduced the risk by about 10%. And this was irrespective of previous diagnosis of cardiovascular disease, and even at those at normal or high normal blood pressure values. I think this is where the major contribution of this paper really comes in, and which really opens up a lot of discussion at the moment. The authors also indicate, and this is where I think it really adds value, is this goes against what current hypertension guidelines actually recommend at the moment. So it says the evidence against the widely held view that an individual's blood pressure or previous diagnosis of CVD per se are key factors for selecting or deselecting participants for blood pressure lowering treatment. So these trialists therefore suggest that we need to revise clinical guidelines globally, and we need to think differently about antihypertensive medication that is a preventive measure. Treatment options for prevention of CVD regardless of an individual's blood pressure level and their previous history of cardiovascular disease. So it opens a lot of discussions also on whether blood pressure medication should be given to anyone. But I think it is also made clear that that is not the idea. Cardiovascular risk estimation should still be done. But it does make one realize that we can do much better globally, with blood pressure medication being very affordable in most countries, that it may indeed be a powerful tool to reduce this burden of the leading risk factor for death in the world. Thank you very much for listening to this contribution to the ISH Cafe series, and hope to see you again soon.